I'm just kidding. All right, everyone, please take your seats. Up next, we got a newborn screening session.
We are thrilled to begin our next session, USA. How it happened, per state, effective mandated screening, featuring a truly remarkable speaker who has had an extraordinary impact on the sickle cell community. It is an honor to introduce Dr. Marilyn Gaston, a trailblazer who has revolutionized the care of sickle cell disease and fought tirelessly for healthcare equality. Throughout her distinguished career, Dr. Gaston's leadership in the Bureau of Primary Healthcare has been transformative. Her pivotal role in advancing sickle cell screening initiatives and her co-direction of the Gaston and Porter Health Improvement Center exemplify her unwavering commitment to improving health outcomes for underserved communities. Today, Dr. Gaston will share her invaluable insights on how genetic disorder testing, including mandated sickle cell screening, has been successfully implemented across the United States for newborns, paving the way for early diagnosis and improved care. Once again, welcome to this important session, and thank you for being part of this vital conversation. Please join me in welcoming the legendary Dr. Marilyn Gaston.
Nobody ever told me my baby might be born this way. He's in there just crying, poor thing. He's been like this all day. And it's such a hurting thing. I had him to the doctor every time he gets these spells. And just today, they told me something's the matter with his cells. The first time they said it was a virus. Just let him get some rest. And then they said to bring him back so they could take another test. But when his joints started swelling and I took him in again, they told me, well, it's just growing pains. You know, children get them now and then. And the fever, Lord, the fever. He'd be hot as he could be. They kept saying, give him aspirin. Just didn't seem right to me. Because it's such a hurting thing. Such a hurting thing. We did everything they told us, pills and rubs and bed rest too, but nothing seemed to help him. Seemed there was nothing we could do. This is a hurting thing. I guess it might have helped for us to know we had the trait. But we love this little fellow and he shouldn't have to wait. And if we hadn't had him, knowing what we do, we'd sure have missed a lot because he's such a pleasure too. If we could just be certain that he'll get the chance he should, then maybe all this suffering will work out to the good because it's such a hurting thing. This is called Blues for My Baby. And this is a poem that two of my very good friends wrote after they started a clinic for interviewing families. And it was back in the early 70s. And they documented what the families were struggling with and what they had, how they had to live, et cetera, et cetera. And they turned this into this artistic poem. And I start every talk with this poem because I think it really gives such a picture of back then what our families had to go through, and such a picture of the sickle cell crisis, such a picture of how nobody knew what was going on, the lack of knowledge of the families, the lack of knowledge of the doctors and the nurses. And being a physician, I can tell you, I didn't know either. I didn't learn anything about sickle cell disease in medical school. Everything I learned about sickle cell disease, I learned after that, after my residency program, after my training. So I just wanted to start with this. And I want to also thank Dr. Rowley for giving me an opportunity to return to the organization and present. I'm really honored to join you again this year. You know, this conference is very important. I want to tell you that, and thank you for including me in it. We have to use every avenue to get accurate information about sickle cell disease out to everybody, all the communities, all the providers, as you know. And clearly, sickle cell disease has been unknown and neglected for years, except for Dr. Scott's work at Howard University, who was doing research and could never get much funding for it, though. But also the work of the Black Panthers right there in California. We wouldn't have known anything without those two organizations that were working as hard as they could to try to contribute to learn about sickle cell disease and then inform everybody. But not until 1971, as you know, when President Nixon drew a national attention to this disease in his State of the Union address, when he targeted two diseases, cancer and sickle cell disease. There's no question, that's when the ball got rolling. 1971, that's when the revolution started. And that's when we began to get funding we got increased attention, got funding for programming, funding for research, medical care, testing, and counseling, et cetera, et cetera, et cetera. So that's why today, this picture that I read from this poem, families are not dealing with this in quite the same way. So I want to say, though, that today, in some areas of the country that haven't had access to the attention that it's gotten, I think we still need to be concerned about getting information to all of them, helping them get in the program. And that's another reason I want to thank you, Dr. Rowley, and your organization for the programs that you're involved in, et cetera, the families and patients you're helping. And I thank you very much. Next slide. Can I see the next slide, please? This is a slide from 1965, and it shows the life expectancy of our sickle cell patients. In 1965, the life expectancy of a baby born with sickle cell disease was only 20 years. When I saw that statistic, I could barely believe it, because through all my life, when I talked about sickle cell, when I talked about life expectancy, it's always at least now 60, 65, 70, 85, 90, and more, it's over 90, and we having more and more centenarians live that long. So to have a life expectancy back then, if you had sickle cell disease, was 20 years, it was just incredible. But in fact, most of the deaths to cause that life expectancy to be that low were babies who died before the age of 3 years of age. And that's the age group that we want to talk about. Can I have the next slide, please? So I want to emphasize that again. The deaths before age of 20 years of life, most of them were before the age of 3 years. And this is what we want to focus on. And this is where prophylactic penicillin has come in, and also the very important aspect that is making the changes that had to be made, newborn screening being implemented across this country. Because back then, not only was it before the age of 3 years, the infection was fulminant, it was overwhelming. It's and specifically from the pneumococcus organism leading to sepsis. When an organism to cause an infection gets in your blood, that's called sepsis or septicemia in the blood. And it could be as fulminant as going from a fever, the onset of fever, to death in less than 8 hours. Can you imagine that? From the time the family would find out the baby had a fever, they had only 8 hours to try to try to get the baby to some help, get them treated, and save their lives. So just think about it. Just think about this situation. Just imagine back then when our babies with sickle cell disease were born without newborn screening. Nobody knew that baby had sickle cell disease. And half the time, the parents didn't even know they had the trait. It was so neglected. I mean, I still have trouble even imagining how they were dealing with it at all. Because they'd go to get their newborn baby. The babies were examined by the OB doctors, but nothing was found, and they were thought everything was fine. And the parents think they're taking home a normal and healthy baby until one night when they go to put that baby to bed. When they go to put that baby to bed and that baby's burning up with a temp of 104 because of this infection, they don't know why. They don't know what to do about it. They don't know who to call. Can you imagine the fear that they had about themselves and this baby? And then they had only 7 to 8 hours to get somewhere that can get treated and save the baby's life. Thank God we're not seeing this anymore. Thank you for newborn screening, because we now have across the country and throughout the world, all babies that are born with sickle cell disease are getting diagnosed and treated with prophylactic penicillin. So because of that overwhelming data in the country, we knew that now we had the money, we had the expertise and everything else to perform a huge research project involving first getting the babies diagnosed, newborn screening, and putting them on prophylactic penicillin to save their lives. And so that's what we did. So we engaged in about 23 medical centers at the top 23 medical centers, hematologists, everybody involved, and in the medical centers to participate and to prove we could be successful. First of all, we knew that the first thing was to do the newborn screening. But we also knew this country, nobody was going to mount a large project of newborn screening of all Black babies before they even knew that prophylactic penicillin would work. So we had to mount that first. Next slide, please. Oh, no, here, I'm sorry. So these 23 organizations helped design the study design. So the study design, just quickly, I will give you a sense of what the study was like, because the whole success of newborn screening and prophylactic penicillin and saving these babies' lives, and now changing the life expectancy for everybody that's born with sickle cell disease. It's much, much better than 20 years old. Praise God. So the study was designed to test whether daily oral penicillin would decrease severe bacterial infection. I told you it's fulminant and overwhelming, and it kills them, especially from Streptococcus pneumoniae or pneumococcus in children less than 3 years of age with sickle cell with SS disease. We studied mainly SS. We did not study sickle thalassemia or SC. All the babies were SS. Next slide, please. So randomized into two groups, one with penicillin and one was a placebo. So it was double blind. Neither group knew what their babies had. Next slide. So the primary endpoint of the study that we had to find to prove that we were dealing with the right organism was to document Streptococcus pneumoniae infection. And the secondary input was to document any other kind of bacterial infection with another kind of organism. Next slide. So we had, for the study, 250 children aged 3 months to 36 months, that's 3 years, at 23 clinical centers. They all had SS disease. They are all confirmed by CDC and family studies. Next slide. So this is the first baby that entered the prophylactic penicillin study. And I was just amazed with his expression. And so he's the first baby you saw on the first slide. He was my favorite of all the babies in the study. Because he was looking like he was asking us, you want me to do what? Do I have to do that? Are any needles involved? Will you draw blood? Anyway, we answered all his questions and all the babies agreed to participate in this study. Next slide, please. So this is a summary of the trial, and this is what laid the groundwork for us to successfully be able to mount the newborn screening aspect. If we hadn't had these data that showed beyond a shadow of a doubt that penicillin worked, if you can look quickly, there were 250 babies total, 105 in the penicillin, 110 were placebo. In the Pilicella group, there were no deaths. In the placebo group, there were three deaths. And not only 3 deaths, but they had, in the placebo group, 13 infections. And the penicillin group only had 2. That is so powerful. Look at that p-value. It's 0.0025. That is an amazing p-value. That means that it's very certain that these results are a result of the penicillin. That the penicillin, they had no deaths if you're on penicillin, and very few infections. There's no question. So it was so compelling. We had a major study group of experts, of sickle cell disease experts that helped guide us through this study. And we all recommended that we had to study. With that, when we saw those data, we weren't going to lose another baby at all. So we stopped it. It was stopped 8 months earlier than when we had planned to stop it, to show you how solid the data were. Next slide. And here, this is just a graphic to again show in the placebo group, the 13 deaths, just to see graphically what a big difference that is. Only two documented septicemias with that showed an 84% reduction in penicillin. Next slide, please. So what did we learn? Prophylactic penicillin worked. So now we were home free. We knew that all the scientists and everybody else were ready now to implement newborn screening across the country. 50% of the events in babies were under 2 years of age. So we had to do newborn screening. There's no question. We had to do newborn screening it was absolutely essential to do that, to start penicillin. We had to put these babies on penicillin before the time they were 3 to 4 months of age, because 50% of the events were under 2 years of age. So we definitely had to do newborn screening. And these data laid the groundwork for people to look at the newborn screening and say, yes, we have to do it. Next slide, please. So the sequence of events is interesting. With that data, we published it in the New England Journal of Medicine in June of 1986. And it was published, the New England Journal of Medicine at that time, back then, in 1986, was the #1 research journal for publications. The best publications were in that journal. And so that was quite an honor that our article from the study documented was in that journal. In fact, it was the lead article on June 19th, 1986. So our hero for everything we were doing around sickle cell disease back then, we had a representative from Cleveland, Ohio by the name of Lewis Stokes. You probably remember him. African-American representative, very interested in sickle cell disease. And he was our advocate on the Hill. He helped us with everything we did. And we couldn't have done a lot of we couldn't have gotten this passed without him. So in June, it was published. In July, we took the publication to him. I remember running down there to him. And when I ran in his office, he said, I know, Marilyn, I know, I heard it. He said, it's such good news. And we were hugging and jumping and screaming and hollering. And we all went to dinner and celebrated. It was wonderful in July. But now listen to this. Within a 3-month period from July to October of 1986, in October, he got legislation passed to provide funding to establish statewide newborn testing. It was phenomenal. First of all, nobody had ever gone from presenting something they wanted to do to having it passed in 3 months. If you follow a bill on the Hill, you would be surprised how long it takes for a bill to get through there. But it was so clear. I mean, there was no question. We didn't have to wait, that we could move, and they passed it unanimously. Okay? That was October 8, 1986. Let me just put a pin right here. I have learned through my years that programs that we are doing, broad programs like this, and the programs you might be doing, that you have to have important partnerships, not only partners that are in the health field, community-based partners, of course, families and patients as partners, yes. But frequently, I also recommend the press to have them on your boards. But most importantly is the political community. And if you're not trying to find somebody on the Hill to be a partner with you and help work with you to accomplish things that you're trying to accomplish, then there's something negative missing there. And I really recommend that one of your major partners has to be one of those legislators up on Capitol Hill. Because if I hadn't had him, there's no way in the world we could have gotten that legislation passed. And he did it, and that paid for all of this that I'm going to talk about right now. Okay. So in October, the legislation was passed. And then in April, we had a national consensus conference at NIH. It was sponsored by NIH, NIH has a program that I think is interesting, and I'll share it with you because you'll probably find it interesting too. That, you know, there's a lot of research at NIH, a lot of publications. There's not a lot of laws passed, but certainly there's a lot of research and passed. And in the past, those people could find cures for something, and it gets published, but then it gets stuck on a shelf somewhere in a doctor's office, and it never gets to the bedside. It never gets implemented. So somebody can have a research project that really solves a major problem, but it never gets out in the world or to the bedside to help the people that need that result. So we were lucky to have NIH agree to help us with a consensus conference on newborn testing for sickle cell disease. And a consensus conference brings all the experts. If something was found that works and the data are very clear, see, we needed to have all the data that I just presented to you for NIH to even help us give us a consensus conference. So we had all of the physicians, nurses, scientists, everybody that have an interest in sickle cell disease. They were involved in this contest. I think there was about 500 people there, and we had all the brains that knew everything, and so that was very important. Next slide, please. So this is the NIH did this poster for us for the newborn screening conference. And I think that's very unique. And it was on all our publications after that, the newborn screening conference. Next slide. So back in 1986, that's when the penicillin public article was published. And I'm going to show you the status of newborn screening in 1986 and 1988. And I want you to look at two major things. First was these were all the genetic diseases that were being tested at birth at that time, okay? PKU, that stands for phenylketonuria. I want you to look at the prevalence of PKU. You have to have 20 births to get one baby with PKU. So 1 in 20 births. Hypothyroidism, 1 in 3,500 births. Galactosemia, 1 in 70,000. 1 in 70,000, galactosemia. These are all genetic diseases. And you probably haven't even heard of maple syrup urine disease. That MSUD is maple syrup urine disease. That's 1 in 200,000 babies. You'll have every 1 in 200,000 is born. And look at sickle cell disease. Our prevalence is 1 in 400 Black babies. Isn't that something? But look at who's got most of the screening going on. It wasn't sickle cell disease. In 1986, only 8 states were screening for sickle cell disease. But then after the publication on penicillin was done, after we had the conference on newborn screening in 1988, look, it jumped up to 30 states were starting to screen. And then in 1993, it went up to 40 states. That was after the NIH conference. It jumped to 40. And then by 2006, all the states were doing screening, and they currently are. I looked at that about 3 years ago, and all the states in the country were being tested. I tried to find some international data to see how many were doing it internationally. I wasn't successful. But that might be a nice little project that somebody's interested in this could look at and find. So since 2006, all the states have been participating in newborn screening for sickle cell disease. Excuse me. Could the voices be lower? Excuse me. Can some, yeah, you want to talk, it's too loud.
No, I got you. Okay, try now.
Okay, thank you. Okay, yeah, you could hear you all. But then the work continued. Next slide, please. So in May of 1989, now this is after all this, the publication conference did a supplement to pediatrics. So we were still publishing the penicillin study, the newborn screening. And in June of 1993, we had a huge conference for the children and families to really hear what was going on with newborn screening regarding accurate diagnosis, et cetera, et cetera, et cetera. I wanted to mention, I don't see it, I had written it down. But there were some really important at the NIH newborn screening conference. There were some things and some issues we dealt with that were important. And I'm looking for this right now. That there were issues that were that we really needed to cover. The first issue was how are we going to screen the children? Who was going to get screened? So the choices were that you would screen only the Black babies. Well, that didn't, we finally had to convince people, especially a lot of the other people that didn't know that you couldn't tell the race of all Black babies by just looking at them. Also, that didn't make any sense to just screen one group of people, because sickle cell disease is in the Arabic community, they're in the Mediterranean community, they're in the Hispanic community. So you couldn't pick and choose like that. So there was a lot of time spent convincing people that every baby had to be chosen. Because there was some resistance to a lot of the white community to stick in their babies when they didn't think they needed to be. The other issue was real important to be sure that no diagnoses were inaccurate. There was also a choice of testing the mothers, doing newborn screening on the babies of mothers that had sickle trait. That wasn't chosen either. So the final decision was that we were testing every baby. And it finally got to be unanimous, okay? I'm trying to think of, there's another thing that was an issue. Oh yeah, there are two other things. And these are real important. That after newborn screening, we had to really drill down and figure out how we could get these babies into care, and especially have their care by sickle cell, by hematologists and other physicians that know about sickle cell disease. Because back then, as you heard, that was not taught in medical school back then. So we had to, it was an issue finding doctors that knew what to do with sickle cell trait, what to do with sickle cell crisis. So that was another thing that was covered in the conference. But also we had to find out, we had to find out early to get them on penicillin by 3 months of age, because it's so early. We were all surprised. at how early that the pneumococcus was causing all that problem. Next slide. So at this point, that's the end of that. Our dream came true, the dream of screening every newborn baby at birth using prophylactic penicillin to eliminate the occurrence of pneumococcal septicemia and eliminating deaths as soon as possible. And then after that was all, everybody, they saw it was in the publication, we had the conference results, etc. And then there were a rash of multiple publications. Dr. Wyszynski, right here in California, he had one where he showed wonderful results in terms of decreasing the death rate. Halassa, 92% decrease in sepsis, on and on and on. Those are just examples. Quinn concluded that sepsis is no longer the leading cause of death in our babies with sickle cell disease. So the next slide. So at that point, we knew that our babies were finally in a safe place.
Dr. Gaston, as you are, we have 1 minute for the rest of your presentation. I know you can't see the chat, so I just wanted to let you know.
Mm-hmm. Okay, I'm finished. If there are any questions.
Yes, ma'am. That was amazing. Go ahead, Farani. We're in your hands.
Thank you. Thank you.
Dr. Gaston, this is Pat Corley. And I always talk about you and when you first started that newborn screening event that changed the lives of children with sickle cell disease. Dr. Cage Johnson, Dr. Darlene Powers,
yes,
here in California, all of those folks.
Yes, I'm so glad you're mentioning them. I meant to do that.
David Satcher.
Yes.
There were just a lot of folks
A
around.
lot of people were
and the leader of our whole thing was a doctor who you worked very closely with, Dr. Clarice Reed.
Yeah, Dr. Reed was head of the whole National Sickle Cell Disease Program. And she chose me to be her deputy. So we worked together hand in hand with all, whatever went on, we were all doing it together.
Yeah, and I most remember your white uniform when you waltzed in to the meetings.
You mean my uniform in terms of the public health service?
Yes.
Yes.
Yes. Yes. And so I just want to applaud you because
when I would walk in. I'm sorry to interrupt you, but I think you wanted to say that I would always walk in to Revolution.
Yes.
We needed a revolution.
Yes. Yes. And to remind people.
This is a person in the government talking about a revolution. I said, well, we need one.
Yes. Yes. And
so we got it.
For all these mothers with children with sickle cell disease, I just had a young lady who I'm meeting for the first time who's with her young son with sickle cell disease that just happened to meet the brother in the lobby, and he invited her to come down. And so she is a mother who has a child who was diagnosed with sickle cell disease. And so I applaud all those mothers who we had an opportunity to help them to ensure that their babies had a full life, even though they had sickle cell disease, because there are so many early on who lost the lives, their babies lost their lives very early on. And so this is a really important and an instrumental presentation, because it tells us from whence we came and where we're going. So thank you, Dr. Gaston, for all you've done over the years to make a difference.
No, we all did it. We all did it. We had teams everywhere, communities. Do you know what? Everybody was so involved that in the neighborhoods, the taxi drivers, they didn't charge anybody that had sickle cell, those families that had sickle cell disease, they would take them all everywhere, to the hospital and wherever they had to go for free. We had everybody on the front line doing what they could do to help us accomplish this. So I'm taking, some credit, but
Thank you.
no, it was a
Thank
the
you.
whole team for a long time that made this happen. And of course, the good Lord.
Thank you. Thank you, Dr.
But thank you
Gaston.
so much for mentioning that. And Darlene and David and do you know, I just heard recently that he was sick and I can't contact him. Does anybody in the meeting know about Dr.
No, not
Sanchez?
here.
Yeah, he's another pioneer. You mentioned all the pioneers. We're Darlene, and there were a lot here right there in California.
Ooh, you have a lot of them. I think Pat, it's time for you and Miss Pat to have a good old catch up
Really?
and conversation.
We
so
got
you can get those
one
numbers.
one last question. Oh, no question? Oh, no, okay. At the end, okay, so we'll do the Q&A. We got one more presentation and then we'll do the Q&A at the end. Thank you,
Thank
Dr.
you.
Gaston.
Yeah, thank
Thank you
you, Dr.
so much.
Gaston.
Thank you for having me. Thank you
Yeah,
so much.
stay on. Don't go nowhere. Stay there. Don't go nowhere. All right, up next, we have our international update with Chidi Jaja.
Hi, Dr. Chidi Jaja. We have a intro video to play. There we go. And then you can bring up your slides.
Annual Hybrid Sickle Cell Disease Educational Summit. Unpacking sickle cell, one warrior at a time. We are excited to begin our next session, International Update, featuring a renowned speaker who brings a wealth of knowledge, experience, and expertise to the sickle cell community worldwide. I'm honored to introduce Dr. Chidi Jaja, an associate professor and Fulbright scholar at the University of South Florida College of Nursing. Dr. Jaja's research focuses on reducing health disparities in sickle cell disease, particularly in sub-Saharan Africa. He has been recognized as a National Institutes of Health Future Research Leader and a Fellow of the American Academy of Nursing. In this session, Dr. Jaja will share valuable insights into international updates, highlighting health protocols and advancements in care for sickle cell patients across the globe. Welcome again, and thank you for being part of this important event.
Good evening, greeting from Florida. Can you guys see my slides?
Yeah,
Is that a yes?
No,
not
we-
yet.
Okay.
We
We
see
saw
you.
them earlier. So do me a favor and stop sharing and then share again.
Sure.
There we go.
Can
Thank
you
you.
see?
Yes,
Yes.
sir.
Oh, Can you tell me what you can see? Because I'm using two screens right now.
Challenges and opportunities for newborn screening.
We can see your slides.
And you're looking at the presentation slides, is that correct?
We are actually
Yes.
looking at your presentation slides, but we see it looks like your
It's not a
speaker
presentation.
notes as well.
Right, okay, that's what I was afraid of. So let
One
me
moment.
see if I can.
Is your other screen that you want to share with us?
Right,
This is the one with your notes.
okay. Hang on a second, I can get this.
We're ready now.
Are we good now?
Yes, sir.
Yes.
Okay, awesome. Thank you so much. Sorry about the technical
It's okay.
difficulties. I have to say that it's a privilege, to be part of this awesome program, but more so a privilege to be on the same panel with the veritable Dr. Gaston. It's like just listening to her for me, it's like going down memory lane, looking at the work that the pioneers ahead of us, the path that they have blazed, and we're just following their footsteps to continue to do the good work. Okay, so we're gonna change our focus for this presentation. We're going to look at the state of affairs for newborn screening in Africa, and specifically in a country in Africa where I do the bulk of my sickle cell work, and that's a country in Sierra Leone. That's a country in West Africa called Sierra Leone. Okay. So my presentation, I'm simply going to focus on the opportunities and challenges for newborn screening in Africa, but then Sierra Leone will be the case study. And what you find out is that the challenges in terms of implementing newborn screening in Africa, and also linking children or babies who have sickle cell disease to comprehensive care, are very much similar to the type of challenges that Dr. Gaston had mentioned in an excellent presentation. I have to say that I'm also happy to be here because what I'm doing is I am not only presenting a viewpoint, but I'm talking about something that I'm passionate about. And folks who know me know that sickle cell disease is my passion. So it's actually a blessing for me to be here to share my viewpoint with you. I have about 41 slides, so I'm going to talk very fast so that we could finish on schedule. Okay. This is a pictogram which basically gives you an indication of where in the world you find individuals with sickle cell disease. Okay. But what it doesn't tell you, though, is that it doesn't tell you about the burden of sickle cell disease. It doesn't tell you about the global burden of sickle cell disease. Where in the world you find individuals with sickle cell disease, how they access care, care-seeking behavior. So you don't get that sense, of what the burden of sickle cell disease is, But if you look at this pictogram, okay, it really brings into sharp relief the areas of the part of the world where you have what in epidemiology we call the incidence and prevalence of a disease. So in this pictogram, you see that Africa has the highest concentration of individual cases with sickle cell disease, followed by the Indian subcontinent. Okay. So when you look at the disease burden, then you're now interested in, well, what's the incidence? What's the prevalence? How is access to care manifested in this environment? What are the care-seeking behavior? What is the natural history of sickle cell disease in the environment where you have the highest burden? So those are the questions that kind of motivate the work that I have been doing in Africa for the last 8 years or so. I'm not sure, how many folks are aware of this, but because the burden of sickle cell disease is greatest in Africa, it's not surprised to find out that each year, each day, about 1,000 babies are born with sickle cell disease. And that's interesting because we know that in the United States, annually we have roughly between 1,500 to 2,000 babies who are born with sickle cell disease. But in Africa, every day 1,000 babies are born with sickle cell disease. Okay? And so now, like for me, well, issue of access to care, what type of health system do these kids find themselves in? And how do we manage such a high prevalence of such a high incidence of birth, sickle cell birth in this environment? But more importantly, sickle cell disease in the African setting is a major cause of under 5 mortality. As was in the 60s, as described by Dr. Gaston, when kids with sickle cell disease barely survive past age 3, in Africa, between 60 to 90% of kids who are born with sickle cell disease would not survive beyond their 5th birthday. So I often say that geography determines babies with sickle cell disease, their life chances, and their life expectancy. So in the United States and in Europe, children born with sickle cell disease have between 96 to 98% of surviving way into adulthood. In Africa, only 10% of kids who are born with sickle cell disease can survive beyond their 5th birthday. So not surprisingly, sickle cell disease has been declared as a pediatric public health emergency. So there are several WHO pronouncements that are urging African countries to establish structures for management of kids with sickle cell disease. There are professional organizations too and advocacy group that have called attention to the burden of sickle cell disease in Africa and the necessity to do something to address this public health emergency. Okay. And the focus has been on identifying babies with sickle cell disease very early, so early diagnosis and screening, and then access to comprehensive care. So now the question you want to ask is, well, why is there such a high infant mortality rate associated with sickle cell disease in Africa? Okay. One of the simple reasons is the lack of newborn screening infrastructure. So here in the United States, infrastructure for sickle cell, for early diagnosis are expensive laboratory infrastructure. Okay. These are not readily available in many African countries. As a matter of fact, they're not even feasible in many African countries for a variety of reasons that include cost. They include the need to have highly trained laboratory personnel. The reagents are very expensive, not readily available, and something as basic as electricity is not really available in many settings in sub-Saharan Africa. So the idea of having a laboratory-based infrastructure for early diagnosis of sickle cell disease, is problematic. But in the last last 7 years, there has been a number of point-of-care tests that are now commercially available that have kind of changed the terrain, that kind of revolutionized the opportunity to do newborn screening in the African setting. Okay. And specifically, there are 3 tests, that I'm going to briefly talk about and show the potential that these tests have in terms of creating programs that will diagnose kids very early, for sickle cell disease, and then put them into a care infrastructure. One of the first new test, point-of-care test, which is actually my favorite, is called the Sickle scan test. And this test basically requires just a small drop of blood, and there are about 6 steps that you go through. You take a drop of blood, put it in a buffer, check the buffer, and pour 5 drops into a cartridge. And within 3 to 5 minutes, you get the result. And you could get 1 of 4 results, or 1 of 4 sickle cell genotypes. So the AA, the AS, the SC, and the SS variant. Okay. So again, it's very easy to use. You don't need extensive training. And the only issue with this test is that it costs $4 per kit, and it is not reusable. The other test is called the Hemotype SC. Okay. This is cheaper. It costs less than $2 per test, and it involves about 6 steps. You could get the result within, I'll say, 5 to 10 minutes. Again, very easy to use, and the advantage that this test has over the sickle scan is that it could give you, instead of 4, it could give you 6 sickle cell genotypes. And then the third point-of-care test, which I call the Cadillac of point-of-care tests. This is the new kid on the block. Okay, it's actually a lab, a sickle cell testing lab in a box. It operates on a battery, okay? And it can give you a much more bang for your money. So you could get about 7 genotypes. This test, unlike the other two, can actually determine not only SS variant, but also the 6 beta tau, which the previous two tests cannot detect. You can also use this kit to determine fetal hemoglobin level as well. The advantage of this test is the fact that it operates on a chip, and the chip can be modified to add additional variants. The test can also be used to test malaria. And now I understand that the manufacturers are working on making this kit capable to do a whole blood count. So in a low resource setting, this is really it's a unique tool that could be deployed to not only identify children with sickle cell variant, but also used for clinical purposes. So because we have this 3 new tests on the, available for use in limited resource setting, I also need to mention that, by the way, that this test, the research that led to the development of this test were actually funded by the NIH. And so not only did the NIH fund the research that led to the development of this test, but more importantly, the NIH is committed, to addressing the sickle cell burden in Africa. So one of the programs that the NIH is sponsoring in Africa is called the Consortium on Newborn Screening, which the program that enabled a number of African countries to now establish pilot newborn screening and train healthcare providers how to manage kids with sickle cell disease and develop a sickle cell registry. So right now, as you can see on the slide, there are about 7 countries, 3 in West Africa and 4 in eastern part of Africa that are implementing this pilot program, which are all designed to increase capacity for sickle cell care in the continent. And I include this slide to give you an indication of where in Africa we now have programs dedicated towards sickle cell screening and care management of children and adults with sickle cell disease. But what I can tell you about this slide, though, is that even though there's a lot in terms of numbers, there are sickle cell programs across Africa, we don't know the quality of this program. And more importantly, not to date, 2024, no African country has universal newborn screening. What they have are pilot programs that are not widely distributed across the country. Usually I find them in urban areas. So newborn screening is still in a very rudimentary phase right now. But there is opportunity to do better. Well, we know that children born with sickle cell disease, you don't stop, once you identify them through newborn screening, for the simple fact that they need to be linked, to comprehensive care. Kids born with sickle cell disease during their lifetime, will be exposed to well over 36 comorbidities. So it's very important, that at a very early stage, they get enrolled into a comprehensive care structure or framework. Well, I did mention that in Africa, sickle cell disease is, a major cause of under 5 mortality. So why is that the case? Now that we can identify kids with sickle cell disease early through newborn screening, why do we still have, a high under 5 mortality rate? Well, there are numbers of factors. I'm just going to briefly run through 4 factors or 4 barriers, that are contributing to this still high infant mortality rate attributed to sickle cell disease in Africa. Okay. The first barrier is there's still, in Africa, limited numbers of centers that provide comprehensive care. So what you could see in this slide is that the countries that have a care program are not evenly distributed, and the numbers too leaves a lot to be desired. Okay. In 2024, here in the West, so we're talking about disease-modifying therapy. We're talking about procedures, options that we could deploy to cure sickle cell disease, stem cell transplant, gene therapy. In Africa, only 3 countries have the capability to deploy these disease-modifying therapies, which is a shame, given that, as I mentioned earlier, the burden of the disease is in Africa. Okay. Another barrier is the limited numbers of healthcare workers, healthcare providers, who can manage individuals with sickle cell disease. There are limited numbers of physicians with expertise in hematology. There's limited numbers of nurses who could actually manage patients with sickle cell disease. So there is there's a limitation in terms of the workforce that can manage individuals with sickle cell disease. Okay. The third barrier is that here in the West, we have a whole range of evidence-based practice and standard of care that we know saves life, that we know that if those standards of care are deployed in any clinical setting, the results, would always be positive. Dr. Gaston mentioned about how they're able to prove that penicillin use in kids can actually save life. So we have protocols, we have evidence-based practice, but these are not routinely applied in the African setting, mainly because, as I mentioned, they're very limited care center and a very limited number of trained healthcare providers. And then finally, cost. Okay. Many African countries are overwhelmed with so many different healthcare issues, and there's a finite amount of money that they have that could be deployed towards healthcare. So across the board, sickle cell disease has not been a priority in terms of money spent for care. As a matter of fact, in the country where I work, okay, sickle cell disease results in more mortality than HIV, but HIV gets 4 times more money, than sickle cell disease. So you have this financial imbalance. And all of these, are contributing factors to why sickle cell disease is still, a cause of mortality in African countries. So now I'm going to switch gears and talk about how the work that we're doing in Sierra Leone to begin to address these barriers that I've outlined. Okay. So so my project is in a country in West Africa called Sierra Leone. In case you don't know where Sierra Leone is, if you look at the slide, the dot on the western side of Africa is Sierra Leone. It's a very small country, has a population of about 7 million people, but has been in the news the last 20 years or so because it has experienced a brutal civil war that lasted 10 years, and it was also one of 3 countries that had the Ebola epidemic. So, but what is of import to us here is that even small country, when you look at the disease burden and you try to measure the burden, you could rank Sierra Leone between 7 to 9 in terms of the number of affected sickle cell births in Africa. And to put things in perspective, annually about 5,000 babies are born with sickle cell disease in Sierra Leone. But approximately 9% of these kids will die before age 5, again, because there is no infrastructure for newborn screening and comprehensive care. And this kid will die because of infection, because of sepsis, malaria, and even stroke. Okay, there's limited infrastructure because the Civil War really dilapidated the healthcare structure. So what we have is a healthcare structure that is in a state of decay. Okay? So, but it's in that setting that we decided that we need to do something, for individuals with sickle cell. Okay. Leon is aware that sickle cell disease is a major problem. As a matter of fact, I was part of a team that put together a white paper in terms of how the disease can be managed. And we published this white paper in 2018, but up to date, the government has not taken any specific action to put were in the white paper into practice. So we decided we're not going to wait for the government to take action, that we're going to assemble a group of individuals that we call champions who are actually going to start to do something to address the sickle cell burden in Sierra Leone. So we formed a group and we call it the Sierra Leone Sickle Cell Disease Project. And we basically had three goals. One, we want to establish, a clinic where we could demonstrate that if you diagnose children early and you put them into a care structure where they could come routinely for wellness care, that they will thrive. And then our second goal was that we wanted to train healthcare workers, provide them with specific training whereby they can begin to manage children with sickle cell disease. In Sierra Leone, where I do my work, there's only one hematologist in the entire country, and physicians are also in limited supply. So we decided that we're going to focus our work with nurses because nurses are the largest healthcare providers in the country. So we're going to train nurses how to be champion to manage individuals with sickle cell disease. And then our third goal was that we wanted to study how sickle cell disease manifests itself in an environment where there's limited access to care or where there's limited resources compared to the West, where access to care and resources are much more in abundance. Yeah. So I'm going to fast forward because there's 2 years of work that I could spend hours talking about that led us to where we are today. But what I want to talk about now is the number of projects that we've been able to initiate in Sierra Leone that are designed to improve the well-being of individuals with sickle cell disease. So I'm happy to say that we have initiated the first newborn screening program in Sierra Leone, which are entirely run by nurses. So we train nurses and we provide them with the resources, the point of care tests that I described earlier. And then the nurses are able to diagnose kids at birth, usually within 24 hours of birth. And then the kids who have sickle cell disease are then provided linked to comprehensive care. And I'll talk about how we do that in subsequent slides. Okay. But as we started to test kids for sickle cell disease, we realized that there's a whole cultural issues around sickle cell disease. One, there's a lack of awareness in the community about the genetic of sickle cell disease. In fact, the languages that are spoken in Sierra Leone does not even have a word for genetics. So how do you explain that sickle cell disease is a genetic condition to people whose language does not even have that concept? We also found out that women are not only the main caregivers of children with sickle cell disease, but they're also stigmatized. They're blamed for having kids with sickle cell disease, and often men would deny any responsibility. So we find that we have a problem that needs to be addressed, and that is to create awareness about sickle cell disease and genetics, and also attempt to reduce the stigma that is attached to the disease, and how women, are persecuted, for having children with sickle cell disease. So that led us.
Dr. Chidi?
Yes, ma'am.
Dr. Chidi?
Yes, ma'am.
You have 1 minute.
Oh, wow. Okay. So, we have, in addition to newborn screening, we also have another NIH program that allows us to train nurses to go out in the community and do group genetic counseling using point of care to determine, to identify individuals, adults, with sickle cell trait, educate them about what sickle cell trait implies, and as a way to empower them to make enhance reproductive decision making, and also as a way of increasing community awareness. Okay. We have also been sponsored last year by a pharmaceutical company called Novo Nordisk to establish 3 clinics across the country that are designed solely for children with sickle cell disease, where they could come on a monthly basis for comprehensive care. And this clinic would be run by nurses. I'm going to fast forward. We've also partnered with a number of NGOs that are working in Sierra Leone to establish a sickle cell pregnancy surveillance program. And we've enrolled about 5,000 pregnant women that we're going to screen to determine if they have sickle cell disease or sickle cell trait. And those who have the disease, we put them in the monthly wellness program and follow them throughout the pregnancy to ensure that they have a safe delivery. And for those women who have sickle cell trait, we'll, of course, educate them about the implication of sickle cell trait. We also have a new project, also likely to be funded by NIH, where we want to follow up our parents of kids with sickle cell disease to see how well they follow up with care for the kids with sickle cell disease. Right. So I have 2 more slides, but I want to share this slide because this slide, I believe, is from the 70s, and this is a community engagement that was sponsored by the Black Panther. I think this would have been in San Francisco, but definitely in California. And this is the Black Panther before sickle cell newborn screening became a reality in this country. They're champions in a society who made it their duty to create awareness about sickle cell disease as a way of improving the life chances of individuals with the disease. And I believe that's what we're doing in Sierra Leone. We are taking small steps to increase awareness about the disease. So this is me and my colleague out doing community screening. We've established a first clinic, and this is where we pictures showing us enrolling our first patient. When we say that clinic, these are the kind of presentation that we saw in our children. But as we continue to provide care, this is what our children look like. And they're all going to be healthy individuals, and hopefully they're all going to be doctors and nurses one day and care for other kids with sickle cell disease. We're training nurses to be champions for sickle cell disease, manage individuals with this disease. And we believe that our newborn screening initiative will enable us to identify affected infants, provide early intervention and access to care for them. And by so doing, we reduce morbidity and mortality associated with the disease. This is my last slide, and it's always a slide that I like to show in a public forum. And the reason why I like to show this slide is that in the history of Sierra Leone, these are the first babies to be screened for sickle cell disease using point of care testing. And these kids were screened on New Year's Day 2018, and I consider them my hero. And that's the end of my presentation.
Thank you so much. We got time for 2 questions. Uno, dos.
There are no questions on the virtual side for Dr. Jaja, so we will do in person.
We have a question. Hold on. It's for Dr. Gaston.
Hi, good day. For Dr. Gaston, I just had a question, and you may have answered it in your presentation. I may have overlooked it. Wanted to see how to formulate my question, but you had something related to the penicillin and benefits for the babies and versus the ones with the placebo, no penicillin. Where does penicillin lie today? Is it deemed useful or harmful?
Oh, no, it's definitely preventing the infections. That's why we're having such good results.
Thank you.
Did I answer it?
Yes.
Okay. Thank you.
We have part
But I
two.
want to congratulate
Follow-up.
all of you on the work that you're doing.
My
And-
follow-up, thank you. My follow-up question was, when is it used and if it's still being useful? Because we all these other medications coming on board.
Well, the penicillin is so, the organism is so susceptible to penicillin. I don't know if they are using another antibiotic.
They're using the same. They're still using penicillin.
Yeah.
I think that's the best thing. I don't see any reason for changing it. And you saw the data. I mean,
The data is still good. Thank you.
Yep.
yeah.
So there was another question from an attendee in the room, and they wanted to know, Dr. Gaston, if your slides could be available.
I can make them available, yes. Mhm.
Okay, awesome. That's the last question of the day. Thank you.
All right, thank you.
So Dr. Riley knows how to contact me, so she can give you my contact information.
Now I'm coming up with Haran. So thank you. All right. Dr. Jaja, thank you.
Yes, ma'am.
No, seriously, thank you. I don't know if anyone knows, in Africa, it's just behind, and in some sub-Saharan countries, they're still dying before 5, even though we have the information and the data, and we even have the medication, and yet our brothers and sisters across the Atlantic, it's still not happening with these babies. So the work that you're doing, we applaud you. You're one person making a difference. And so we always want to know how we can partner. How can we partner? We have a partnership with Kenya. And so they're doing work. Eunice is here. She'll talk about that. So Dr. Jaja, thank you. Dr. Gaston, thank you. If you guys have time,
Thank you.
we invite you to stay for our celebration of life, please. Our celebration of life will be starting literally in just a few minutes. And it is an honor of those who have gone before us. May they never be forgotten. So if you all, Dr. Gaston and Dr. Jaja, if you're able to hang with us, we have a beautiful presentation, and then we'll be going out. Everyone has their candles, and we'll be going outside shortly, lighting the candles and having another presentation candlelit. So I appreciate you. Thank you.